I'm very, very delighted to announce our next speaker. Dr. David Petrino, hi, I can see you, is a physical therapist with a PhD in neuroscience. He's the Director of Rehabilitation Innovation of the Mount Sinai Health System and Professor at Department of Rehabilitation at Icahn School of Medicine at Mount Sinai. His passion runs deep. He's not only a researcher and a clinician, but also a close advocate and ally for us people suffering from long COVID, engaging with the community regularly in Twitter. In the opening statement of this conference, we heard Ed Young, and David Petrino shared on Twitter that he met Akiko Iwasaki through Ed Young, and they have been united to fight, and we have bringing this to the global stage, as we heard yesterday. And I'm very, very happy that Dr. Petrino is addressing today a broader perspective on post-acute infection syndromes. And he's always advocating to take these conditions serious as somatic, and we do desperately need to look deeper into them. So Dr. Petrino is going to talk about demystifying diagnostics, biology, I'm sorry, I can't pronounce this word, and treatments. So Dr. Petrino, if you are ready, the stage is yours. Thank you so much.
Thank you so much for having me, and it really is an honor to be here, and I want to thank the conference organizers for putting together such an enormous meeting. I'm just going to go ahead and share my slides right now. And, 20 minutes to do all of this, no problems. I think what I want to do today is really talk about how we're conceptualizing post-acute infection syndromes, how we're thinking about the pathobiology and pathways to treatment. And, the first thing that I want to say, the reason I chose to entitle this talk, with the word demystifying, is post-acute infection syndromes are not mysteries. What they are under-researched, complex chronic illnesses. They're not simple, and they don't fit into frameworks that conventional medicine is comfortable with, but they are not mysterious. And they're, what I hope that everyone takes away from this presentation is that there are so many open avenues of investigation to really meaningfully help people that we haven't even scratched the surface of. And so with that, I was really enamored by the title of the conference, that we're here to unite. I want to really point out that when we talk about long COVID and ME/CFS and chronic Lyme disease and fibromyalgia and other conditions that may be sort of put under the bucket of infection-associated chronic illnesses or post-acute infection syndromes, I think we need to always keep at the forefront this idea that if we're a united community, we are a stronger community. And uniting to address all of these issues together is so important. When I think about post-acute infection syndromes, I think about a myriad of conditions, and this is by no means an exhaustive list. This is a handful of things that we think about in the context of post-acute infection syndromes, infection-associated chronic conditions. Every single thing that you see on my presentation today is incomplete. So please don't see this list and say, what about this? What about that? I will acknowledge there are many more conditions that I can't fit on a simple schematic. And I also want to acknowledge that we don't even right now have adequate terminology, because we talk about post-acute infection syndromes and infection-associated chronic conditions, but many people are suffering. Many people are suffering in ways that were triggered by other things, not just infections. So although many post-acute infection syndromes, or many of conditions that are often designated as post-acute infection syndromes or infection-associated chronic conditions, although the majority tend to have a triggering infection point, so whether that be a virus or a bacteria that is the triggering moment. We also have people who are sick with similar symptoms and a similar lack of treatments due to exposure. We have people who are sick because of vaccine injury. We have people who are sick because of mold exposure. We also have people who are sick in similar ways due to trauma and immune challenges, such as traumatic brain injury, pregnancy, car accidents. Our recent the recent Nature paper that was just published that was looking at how inflammation in the brainstem can activate, vagus nerve dysfunction and dysregulation, really give us an understanding of how trauma and immune challenges that are non-infective may trigger some of the symptoms that we're seeing. So again, I really want to make this talk about a call for unity and a call for an understanding that there are more things that that unite us than should divide us. Why and how are people being made sick by these illnesses? Now, this was a great review paper. Everyone is probably tired of seeing this image. It's sort of, someone puts this image up at every conference. So we're not going to spend too much time on this image because, this was a great image from a Nature review paper, but I actually think it's a way more complicated than that. And I think we need to delve into the complexity if we're going to make progress. Once again, this is a map that I created that is by no means complete, but every single thing that we have on this map, we have really solid evidence to support it in peer-reviewed journals, and peer-reviewed journals that are of the highest order, to say that folks with post-acute infection syndromes will present with things of this nature, and they're most likely correlated with symptoms that are being presented. So today's talk, we're primarily going to zoom in on these and talk about viable treatments that have not yet been adequately tested that we need to be moving on now, or yesterday, as the case may be. So moving off to the far left of the map, we start with persistence and co-infections. We have strong evidence to suggest that viral persistence is real and in many cases is a significant driver of at least some of the symptoms that we're seeing in post-acute infection syndrome. Also, of course, bacterial persistence when we're talking about things like tick and vector-borne illness. I really want to draw a line in the sand here and say that there are deniers of pathogen persistence, but they're not serious people. The people who are denying that pathogens exist, that pathogens persist in the body, continue to hang on the literature and say, well, you haven't shown us alive and replicating pathogens in people. But what we have shown over and over again are, remnants of these bacteria and proteins that live bacteria produce, that really there's not really a good explanation for why these proteins and antigens are in the body, other than the fact that the virus is still alive or persisting. Or let me rephrase that to say that the most feasible and the most logical explanation for why these antigens and proteins are in the body are because we have alive and replicating and persisting pathogens. And in addition to that, we also know that there are many studies that are starting to show live pathogens in the body. So, and certainly in animal models, this has been a done deal. In animal models, we've seen a live and replicating virus for many, many years. These are just experiments that are difficult to perform on live people, which is why they haven't yet been done. But we shouldn't forget the fact that they're there. And then, of course, as speakers like the amazing Akiko Iwasaki have presented already, we know that co-infections, latent viruses, reactivate when disease states such as a post-acute infection syndrome are triggered within the body. So to that end, we have a myriad of drug targets that include antivirals, antibiotics, monoclonals, combinations of antivirals and monoclonals, combinations of antibiotics and immune therapies that haven't been tried, that need to be tried in order to in order to either rule things out or move things forward. And I know that there are folks who have been in the field for a while and they say, look, if antivirals worked, we would know it. I respectfully disagree with that position because, you know, there are antivirals and there are antivirals. And a lot of the antivirals that are available to patients right now, they don't penetrate tissue. They're not going to address viral persistence in the central nervous system. And so as a result, we need to develop new drugs in addition to trialing existing drugs in order to actually answer the question of what is the role of antibiotics, antivirals, and monoclonal therapies in treating post-acute infection syndromes. Immune dysregulation, once again, we've had many great speakers so far and many to come that talk about all of the immune dysregulation that we see very clearly in post-acute infection syndromes. And so I really want to point out that with these immune dysregulation findings, there are a number of drug targets, FcRn inhibitors that can address, you know, functional autoantibodies, BC007, which is being trialed in Germany right now, you know, that I think is incredibly promising to address GDPCR, PC, oh my God, the autoantibodies that are being produced in some folks with long COVID, complement inhibitors to trial to see if some of the elevated complement that is being seen in folks with more acute on chronic post-acute infection syndrome. So, you know, under 5 years sick or under 10 years sick might be addressed with complement inhibitors. Immunotherapies like rapamycin and Ampligen, these are trials that should be available to the post-acute infection syndrome community yesterday to see if they address immune dysregulation. And another caveat I'll make about everything that I'm saying here is that when I talk about trials, I'm talking about trials that every patient is deeply phenotyped as they're going through the therapy, so we can identify who's a responder, who's a non-responder, and if they are a responder, why are they responding? What physiological changes are accompanying the response that we see? That is the only way that we're going to be able to create subsets of individuals with post-acute infection syndrome that can predict who is going to respond to different therapies. We know that there are a myriad of hormonal changes that are occurring in folks with post-acute infection syndromes. I was really, proud to release a new preprint with Akiko and her team, led by Julio Silva, to show some of the amazing changes that we've been seeing in sex hormones in folks with long COVID. But we also know that these changes have been reported in folks with ME/CFS in the past as well. And to that end, there are a lot of drug targets that we could be focusing on hormone replacement therapy, testosterone, bioidentical progesterone, cortisol therapies, steroids, many other hormone replacement approaches. Again, I'm not an endocrinologist, so I'm not going to sort of hit you with all of the different permutations and combinations that could be prudent to try here. But the point is that there are a lot of leads to follow that we aren't following. And there are a lot of clinical trials that should be occurring that we should be advocating for as a community. Endothelial disruption. The amazing work by Riccia Pretorius, Doug Kell, and many, many others in this space who have been showing that long COVID, and now some of this work has been replicated in ME/CFS, and we hope to replicate in other post-acute infection syndromes, that these illnesses come with endothelial damage and endothelial dysfunction. To this end, there are so many drug targets, such as antihistamines to address mast cell activation syndrome, which goes hand in hand with endothelial dysfunction, mast cell stabilizers, antiplatelet therapies, proteolytic enzymes such as nattokinase, serrapeptase, lumbrokinase, pycnogenol and resveratrol to improve endothelial health, even statins to improve endothelial health and improve the health of the blood vessel. These are all things that we should be actively trialing. And these are all things that clinicians can try with their patients because there are peer-reviewed clinical trials showing that some of these agents significantly improve endothelial health already. So they can justify attempting off-label treatments. Neurologically, we know that many post-acute infection syndromes come with damage to the central nervous system, neuroinflammation, dysfunction of autonomic nervous system areas such as the vagus nerve. There are, again, a myriad of drug targets that we should be looking at, such as blood pressure meds and beta blockers for POTS, with the understanding that monotherapies aren't going to get it done. If you have POTS and you've tried drugs, you probably know that there is a lot of trial and error that needs to occur before you find a drug regimen that works for you. So we need more sophisticated clinical trials in this domain than simply, hey, we tried ivabradine and it didn't really seem to work for most people. Ivabradine will work for some people and it won't work for others. Understanding why it works for some people is the next question. Hyperbaric oxygen therapy, use of psilocybin as it is able to improve mitochondrial function in serotonin poor situations, and low dose SNRIs are all examples of targets that should undergo extensive clinical trialing in safe environments so that we can better serve patients with post-acute infection syndromes. Gut dysbiosis is a huge issue that we have seen from the very beginning. There are a number of drug and supplemental targets that simply, either have been trialed but haven't been trialed enough, such as SIM01, which has a wonderful randomized controlled trial out there showing good efficacy in folks with long COVID. This should be tried out in many, many other post-acute infection syndromes as well to address gut dysbiosis. And then, other molecules and supplements such as 5-HT, tryptophan, etc. And finally, we have the mitochondrial and metabolic dysfunction that we frequently see in folks with post-acute infection syndromes. For a myriad of reasons, individuals will go on to develop these issues that are related to the disease process, not to deconditioning. And there are many, many drug targets here, metformin, a myriad of mitochondrial supplements, a myriad of antioxidant supplements, a myriad of ketogenic supplements that are early to the market that mimic the effect of ketosis on people without actually having them jump onto a ketogenic diet, which can run rampant on certain symptoms due to the sort of restricting eating patterns that go along with it. So I know that when I talk about this is kind of the vibe that often gets transmitted. But I need to sort of help to people to understand the complexity, and then I also need to acknowledge the fact that many people with PACE, of all the different things that I showed on that tree, sometimes you'll have all of them, sometimes you have just one of them, but it doesn't mean that it's not incredibly debilitating if it's going untreated. So, the work that needs to be done by clinicians in the space and researchers in the space is to understand what configuration of PACE patient is sitting in front of them and what is going wrong in their bodies that is leading to the symptoms that they're seeing. And we have not done any of the necessary deep phenotyping studies to better understand that. So, to end the presentation, I just want to talk about the fact that, once again, complex illnesses require complex solutions. A single drug or trialing a single drug and walking away saying it didn't work is not going to get it done for the community. We need more sophisticated approaches to drug trials. We need combination therapy trials. We need adaptive platform trials. so that we can find the combinations of drugs that work for the patients who have the combinations of body system dysfunctions that we're seeing evidence of. And so, you know, I just want to end again with a message of unity. You know, what does unity look like? If we are all committed to uniting to fight, it means inclusion and equity at every level, in conferences, in patient-facing clinics, in clinical trials, in clinical trial planning. It means including all of the stakeholders. Everyone gets a seat at the table. It means avoiding zero-sum game situations where we pit one condition against the other condition. And to that end, it also means that we focus our anger and our action on government structures, not individuals who are trying to help, but may not be necessarily helping in the way that you think is most productive. Understand that when we talk about the systemic change that is needed to come up with cures and solutions for everybody, we need to be focusing on government action. We need to save our anger for the people in power who are sitting back and doing nothing, or sitting back and telling you that 20 to 30 years for a cure is an acceptable time frame. That is an unacceptable time frame. Good science doesn't take time if you resource it well enough. Good science can happen overnight. And there are enough of us out there to make this happen. And so I'll just end my presentation by just reminding everyone of why we fight. Reminding everyone of Lauren, who has been platformed by this conference, and of so many countless others who have taken their lives rather than live with the severity of the symptoms. I would remind us that, you know, the fact that, again, that we have government research entities telling us that we're making good progress while this is going on is a cause for fight. It is a cause for us to get angry. It is a cause for us to raise our voices. And we cannot forget the millions of people who have disappeared from our lives because of these post-acute infection syndromes and associated conditions. So I'll leave it there by thanking everyone who has given me support, and my incredible team, and all of the patients who contribute to our research. And I believe we've got 10 minutes left for questions. So thank you all for having me again.
Thank you so much for your passionate speech about unity, and that we should address our energy towards the people who can help make the science come true tomorrow. And thank you also for addressing Lauren, and my heart goes out to her family and her mother. So thank you very much for this enlightening speech. I'm a bit speechless because I have tears in my eyes. I'm sorry, but I'm trying to focus on the questions now. I'm trying to make my best to not overlook any questions. And thank you very much for the kind contribution from the community. Okay, the first question from Miriam. Can you publish, or have you already published, a treatment protocol for other doctors to follow suit?
We have been working to publish different treatment protocols. We worked with a number of different organizations to publish, especially we had some treatment guidelines in the AAPMR, American Association of Physical Medicine and Rehabilitation. I would also love to shout out to Long COVID Physio, that have done an incredible job of multilingual services for rehabilitation resources that are helpful, you know, and I know that this conference heard from Todd Davenport just yesterday, and, you know, he's now the president of Long COVID Physio, and they've done a great job of resources around pacing and energy conservation and so on and so forth. And then we are working on a new website, which is coming very, very soon, where we will be putting all of these protocols down, you know, as we learn them. And I will say, you know, as we learn them, because I've only been in the space since 2020. We are still learning, and we are making missteps in our clinic. You know, and nothing that we do is perfect right now. But as we develop protocols that are working, we're frantically looking to publish them on this website that we're developing. So keep an eye out on us as we start to publish those.
I just have to say, you're doing a fantastic job. I've been a patient since 2020 and I've seen a lot, but you're setting the bar extremely high. So thank you very much for that. Okay, so the next question. What can we as a global patient community do to support you and your research colleagues to help accelerate research into these dreadful conditions? You're such a great advocate for us, and as you know, we are eager to do whatever we can to support you.
That's such a kind question, and I think, in general, I think we need to find ways to get the government's attention in different countries, and I would say that from my perspective, and this is something that I again, since 2020, I've never really been someone who talks to governments or gets involved in policy change or things like that, and it's not my expertise, and it's certainly not my skill set because I lose my temper too easily. But I will say that having if we can pull together advocates that do understand this world and can get into the ear of politicians to talk about this, because the one thing I will say, and I can speak for the United States at least, is that politicians here are starting to get scared. The impact of post-acute infection syndromes, because of the sheer number of long COVID patients that exist in the world, is starting to make people see reality. It's starting to make them change their mind. And so presenting a united front to politicians and saying, hey, this is, we need to, there are people who can speak about this, and there are people who know how to direct research programming, that is more effective than in 20 years, maybe we'll have some publications, but no treatments. I think that we need a lot more government action. And, and I hate to put this on to a patient community who is already at limited spoons and doing a lot. But to me, I think that that's where all of us need to be placing our attention right now, is getting our governments to listen to us.
Yeah, that's very important. Thank you for stressing that point. Yeah, we can't stress that enough. Okay, so I have another question for you, and it's related to your talk. What kind of combo antivirals do you see as most promising targets for your trials?
Yeah, I think so. I'm definitely interested in, given the literature right now, one of the things that I'm most interested in, which is kind of phase 2 clinical trials for our team. But if anyone wants to steal the idea and has the funding to get ahead of us, please do. But, I'm particularly interested, for things like long COVID, for instance, where we know the triggering pathogen. I'm particularly interested in combinations of targeted monoclonals with broad spectrum antivirals. So things like Truvada paired with, an alpha generation, a delta generation, or an Omicron generation monoclonal, depending on when you got the triggering infection that caused your long COVID. When we think about antivirals, I'm particularly interested in making sure that the antivirals or the monoclonals that we're using are targeted to the specific pathogen. And so, one of the things that we need to do better is actually have a research platform that allows us to identify persisting pathogens and which pathogens are persisting in people with post-acute infection syndromes. Because otherwise you're taking a shot in the dark when you're using antivirals, which is why I said initially, if we knew, people who say, well, if antivirals worked, we'd know by now. Not really, because we don't even have tests to understand which viruses are present and causing problems in people who are so sick. We only have tests to understand which viruses our body thinks are causing the problem, i.e., what antibodies are we producing?
That's very interesting, because right now people get reinfected all the time, so we actually don't know when to start, at what variant, right, to treat them.
Exactly.
Yeah. Perfect. We're coming to an end. I would one quick question, because it has been upvoted so many times. I don't want to not ask you the question, the last one. So many healthcare providers are oblivious to the research findings, 400K papers, and often continue to do harm. How can we push their professional bodies to support and demand better from their members?
Yes, again, this is a great question, and it's a huge problem. And again, I come back to my answer about pushing government bodies. You know, we need to help governments to understand that this is a malpractice issue now. If a PCP, a primary care practitioner, or a general practitioner in other parts of the world, sees a patient with ME/CFS and recommends graded exercise therapy, that person needs to be held accountable. That person needs to be told that it's malpractice. The first thing that we need to do, the first advocacy goal that I think is very important, is establishing a home for post-acute infection syndromes. What is the specialty, or what is the type of physician that sees them? And then we start educating. Those people need to be rapidly upskilled in seeing long COVID patients, because it's not a malice problem, it's an education problem. And so we need to educate folks. We need to, just like any other condition, we need to make sure that there are consequences for mistreating people against therapeutic guidelines. And that all has to come from the top.
Yeah, I couldn't agree more. And I hope we have made a start with this conference, since we had our German health minister opening the ceremony, acknowledging the efforts of Unite to Fight and some other senators from around the world. So I think we made a start, and I hope we can keep going these efforts together and as a community and united to fight. So thank you very much, Dr. David Petrino. It was an absolute pleasure to have you here today. Thank you so much.
Thank you, and continue the good fight. Thank you.
Thank you.